Hello everybody and welcome to the B. Brown Satellite Symposium. My name is Miriam Kirsten. I am speaking to you from Switzerland and I'm Global Product Manager at B. Brown Avitum.
Hi Miriam, hello everybody. I'm Dr. Susana Peñuelas. I'm located in Lisbon and I'm the Medical Director of Wound Care and Infection Control at B. Brown Avitum. Our question today is, why do we still need to talk about wound infections? Miriam, you would think that this topic has already been extensively covered, right?
Absolutely, Susanna. But in fact, there is still ambiguity of how to diagnose a wound infection and also how to treat or to prevent it. Therefore, your choice matters in today's B. Brown Symposium, where we have a well-defined agenda to discuss early intervention strategies for wound infection management. After Susanna introduces the ongoing relevance of today's subject, Professor Dr. Karen Osey will be joining us from the UK to present you the wound infection continuum to diagnose chronic wounds.
Right. And Miriam will then show you how we can prevent and manage wound infections, and this will be followed by today's patient's case that will be presented by the nurse in charge, Fernanda Belén Cortés Rojas from Chile.
At the end of our symposium, we will have a Q&A session, so if you have any questions during the presentation, just drop them in the chat box. But at first, let us now listen to the patient himself. This is the story of Miguel Jopia Cuevas, a 60-year-old patient from Chile who suffered from a pressure ulcer after he was hospitalized with COVID, which left him with a constant fear of getting a wound infection.
Dear friends, I want to share my hospital experience after I had been there for 39 days. My name is Miguel Jopia Cuevas. I am 60 years old and I was infected with COVID in March 2021. I had 2 intubations and I survived COVID. I lost about 19 kilos, more or less. This obviously affected my muscles and muscle tone. And with the weakness that comes with losing so much weight, my lower extremities could not support my body. In addition, there was a significant pressure injury of 12 centimeters in the lumbosacral area. After these 39 days of hospitalization, I was discharged. I left hospital with a pressure injury, a bed sore. I needed to get treatment every 72 hours. This meant that I needed the services of a professional nurse that would perform the treatment at my home, which of course costs a lot. This also means that I cannot go to work and perform my usual tasks. The inability to move normally has influenced my sleeping patterns as well. And the strong smell of the wound is uncomfortable for the rest of my family. The treatments are quite painful because the site is not anesthetized, which leads to the fact that it also affects you psychologically. Since it breaks your first protection barrier, namely your skin, you are defenseless against external influences and are constantly at risk of getting an infection. So far, this has not happened because the nurse who attends me is very good. Mood swings occur, of course. These restrain you also psychologically. It affects everything, your emotional life, your family life, with everything that goes with it. Right now, my injury has still not healed 100%, and I'm still on medical leave. I'm still not working, but I do have expenses. It's a complex issue, a serious problem. What's more, bed sores can even lead to the death of people. I do not have any pre-existing diseases. I don't have diabetes. But I don't even want to think about what would happen if this was the case. So my message is that these things need to be taken seriously and to create awareness that this has to be a holistic process. This should not happen again.
Hello again, everybody, and for those who haven't been in the prior presentation, I'm Dr. Susana Peñuelas. I'm the Wound Care and Infection Control Medical Director for the Medical Scientific Advice in Abitum B. Brown. And I'm here to try to answer the question, why do we still need to talk about wound infections? Well, I will lead you in these minutes through these few points, talking about the relevance of the skin, the accessibility of the skin, the movements forward and backward that the wound healing has had in the course of history, and also why prevention is the key and how a wound can be life-threatening. As wound specialists, you of course already know that skin is the human body's largest organ. But have you also thought that it is the most visible and accessible? We all have access to our skin. We all realize what happens with our skin. We realize when we have a wound. And that's why the human beings always have taken care of their skin and their wounds, because they could see it and they could manage it. So it was not a professionalized care. It was amateur for many, many millenniums. If we go to the animals, they already take care of their wounds or their skin. And we as human beings can say that the history of the surgery, the history of the medicine is linked together with the care of the wounds. Yeah, we may suppose that it was a matter of trial and error, that the primitive human beings chose the remedies, chose the herbs or the substances to treat the wounds, and that they were kind of improving in this knowledge. However, it has not always been a progress line. When it comes to wound healing, in the Middle Ages, for example, the wound suppuration, which means the wound fluid discharge, was an objective itself, rather than the rational use of topical preparation to achieve the healing. They prefer suppuration because also rituals, mythological thoughts, religion played a role in the wound healing. So it has not always been a progress movement. That's why we may ask ourselves if now we may be in a worse moment than in the past. And as our next speaker will tell us regarding antibiotic resistance, we may indeed now be facing a worse time than before. We may be facing the worst moment since we discovered antibiotics 100 years ago. If we look at the wound infections, if we look at the pathogens that we may find in a wound culture, the usual pathogens are those well known by all of us, like the Staphylococcus aureus or the Enterococci, the Escherichia coli, the Pseudomonas. Well, if we go to a list of superbugs, which are the bacteria that are resisting the current antibiotics, let's see. We find again the Staphylococcus aureus. We may find the Enterococcus, the E. coli, the known Pseudomonas. Yeah, you see, the list of superbugs pretty much is related to the list of the bacteria that you may find in a wound. That's why an infected wound can be infected with superbugs. And it can lead to a sepsis, to an antibiotic-resistant sepsis. That's how a small wound can be life-threatening. Because each year in the world, 26 million people suffer sepsis with up to 6 million deaths per year. This is more common than a heart attack. And the causes of a severe sepsis are not only a pneumonia, a bowel perforation, or a urinary infection. It can also be a severe skin infection. That's why in any patient with an infected chronic wound that suffers from a sepsis, the chronic wound can be or should be even considered as the cause of that sepsis. And you can see that when this patient has underlying comorbidities that reduce the ability to resist the wound, it will also reduce the ability to resist the infection, and the outcome can be lethal. For all the said, prevention is the key, because you won't be only saving money, because the cost of a treatment has been found to be 3.6 times more expensive than prevention, but you will also be saving lives. That's why you should focus in preventing the local infection, by managing the pathogen load and the biofilm, as we will see later in the presentation of Miriam. And you should then prevent a systemic infection if a local infection is already in place. For all of this, you shouldn't look only at the hole, at the wound, but you should look at the whole patient, and think of an holistic management addressing both intrinsic and extrinsic factors when it comes to wound care. You should especially pay attention of decreasing the biofilm nutrition, as we will see in the coming presentations. For doing this, you need to do a right assessment. That's why I would like to bring your attention now to the TILI score, which is a recent publication of Disemon and his group. And this is a therapeutic index for local infections that helps us professionals, but also those not specialists, to diagnose or correctly address a wound infection. This score has two charts, one of them showing the direct indicators, like the presence of the wound pathogen, a surgical septic wound, or the clear presence of pre-pus, but it also has a chart with the no direct indications, such as erythema to surrounding skin, the heat, the edema, the pain, the stallage when the wound is not healing, and an increase or change in the color or smell of the exudate. But be careful, because as our next speaker will warn us afterwards, Karen will talk us how easy it can be to confuse between infection and inflammation. As you see, these non-direct indications are also matching the classical inflammation signs: rubor, calor, tumor, dolor, and function lesa. So that's why I would like now to welcome our next speaker, as I said, Dr. Karen Ose, who is Professor of Skin Integrity, Director for the Institute of Skin Integrity and Infection Prevention in the University of Huddersfield, and Chair of the International Institute of Wound Infections. Karen, thanks for joining us today. As an experienced nurse and one of the authors of the consensus on wound infection continuum, you are certainly the right professional to explain us how to apply the wound infection continuum to diagnose chronic wounds. Thank you for being with us.
Thank you very much, Susanna, for that lovely presentation and for the introduction. Hello, everybody. As Susanna's just said, I'm Karen Ose, Professor of Skin Integrity, and I'm going to look at applying the wound infection continuum to diagnose chronic wounds. And you can see there an image of the wound infection continuum. Not going to talk about that at the moment, because I want to have a little bit of a chat about antimicrobial resistance first, because that very much links into the wound infection continuum. So, as you're all well aware, wound infection is something that we really do need to prevent. And if we can't prevent it, we need to be able to assess it and manage it appropriately, but in line with this global threat of antimicrobial resistance. And antimicrobial resistance is an umbrella term that incorporates effective and judicious use of antibiotics, antifungals, anti-yeast, and of course our antimicrobial wound dressings. So it's absolutely essential that we understand the wound infection continuum, so we know when a wound is infected or when a wound is in fact inflamed. And as you can see, antimicrobial resistance is important globally. There's been lots and lots of different publications over the last few years that have identified countries' ways of being able to manage this. And most recently, the Global Alliance for Surgery has published their document that looks at antimicrobial resistance in light of COVID-19. So if you get a chance, just have a look at the action plans for your own particular countries, because they will actually relate to what you're doing in practice and impact upon your wound management as well. But you may be thinking, why are you telling us about this? We actually want to know about wound infection. And that's because we've used antibiotics for many years, as you know, but it's been 30 years since we've had a new antibiotic introduced. So it's absolutely vital that we do assess our wounds correctly, and we know when they are infected and when they really do need an antibiotic. And similarly, we need to know when to use an antimicrobial. The wound isn't infected. Do you really need an antibiotic? And do you really need an antimicrobial? And we need to be looking at how do we get more antibiotics that are new and researchers at the moment are investigating this. So I am hoping, and I'm sure yourselves are hoping, there will be some new antibiotics developed over the next few years. But we can talk about antimicrobial resistance, and we can talk about antimicrobial stewardship and understand the importance of effective use of these, of antimicrobial wound dressings. But first and foremost, when we go and look at our patients who we think may have a wound infection, it's absolutely essential that we have effective assessment and we can identify correctly. And in fact, when you look at these images here, many people will think that's very clearly an infected wound. So we maybe need antibiotics or we maybe need antimicrobials, when in fact these are all cellulitis. And as many as a third of patients are misdiagnosed with cellulitis that cost within the UK 132,000 bed days and £84.5 million is wasted on inappropriate use of antimicrobials. So again, you can see why we need to get a correct diagnosis by in-depth identification of our wounds. And we know that when we look at wounds, we can decide whether or not they're infected or not infected. And we need to understand how to treat them. And often these infected wounds are treated using a combination of topical antiseptics or systemic antibiotics, depending if they are infected or non-infective. And as I said before, it is this risk of antimicrobial resistance that really makes us need to understand how do we recognise infection. And in fact, if we don't learn how to recognise infection appropriately and keep misusing antimicrobials, by 2050, we're going to see in excess of 10 million deaths directly as a result of antimicrobial resistance. And this will be more than the cancer deaths. So again, this is why we're going to talk about the wound infection continuum. And I would like to draw your attention to this document where the wound infection continuum is embedded into it. This was published in 2016 through the International Wound Infection Institute. And it is principles of best practice for identification, prevention and management of wound infection. The document is currently being updated because, as you can see, it's 5 years old now, and the new publication will be launched in March next year, March 2022, at the World Union of Wound Healing Societies. But at the moment, this is the document you will be using. However, after it's been launched in March, you'll be able to download it free of charge from the International Wound Infection Institute's website or Wounds International website. And similarly, you can download this one free of charge as well. So when you get a minute later, please do have a look at it, because there's very useful hints and tips in there, as well as an overview of the evidence. So as I say, embedded within that document is the wound infection continuum, which is on the screen in front of you now. You can quite clearly see this contamination and colonisation commences continuum, and this is where no antimicrobials are used at all. You just need to be vigilant. So keep looking at the wound, keep assessing the wound, and obviously speak to the patient. How does the patient feel? Do they feel unwell? Have they got a pyrexia? Is there any exudate or any malodour coming from that wound? If there's not, then the wound's not infected. However, if we've got local spreading or systemic infection, then we need an intervention. So we need to be looking at topical antimicrobials and systemic and topical antimicrobial use. And again, we must remember, when you look at these wounds, if you've got lots of exudate, so it may be green and yellow and looks really unclean, all wounds should be cleansed prior to assessment, because you need to see what's going on at the wound bed. You also need to consider antibiofilm strategies as well, and there will be lots of local guidance that you can refer to. And again, you can see on the continuum here that at this point in time, when this continuum was developed, biofilm was saying be considered from back colonisation to systemic infection. However, there's been quite a lot of research since then looking at biofilm, and we should always consider biofilm if your wound isn't healing in the normal trajectory as you would expect. And again, look at your local guidance as well for biofilm. So we've got contamination and colonisation where no antimicrobials are required, but then we have local spreading and systemic infection where we'll need some intervention, which will include antimicrobials and maybe antibiotics. But you may be thinking, well, how do I differentiate between these terms? Well, again, within the document by EWMA, there's this really nice table that quite clearly identifies and lets you know exactly what you need to be looking at. So, for example, contamination. All wounds have microorganisms. That's normal. If we swabbed any of our cells currently, we would have contamination. And similarly with colonisation. However, when we get to local infection, there's two signs. There's the covert signs, which are those subtle signs of local infection that include wound breakdown and delayed wound healing, and the overt the overt signs that you can clearly see, which are erythema, local warmth and swelling. But then you may have spreading infection, which again is an extension really of those overt and covert signs, but the wound is deteriorating and the patient's also feeling generally unwell. If we get systemic infection that really we want to avoid at all costs, there's risk of severe sepsis and septic shock and then death. So it's really important that we understand all these signs. And again, we can look at these local indicators and be able to develop our care plans around them. And again, within that document, you can see what you need to be looking at. So assessing the wound bed, assessing amounts of exudate, and remember to look at that peri-wound area. You don't want that to become excoriated and macerated. Important that's kept dry and correct dressings are chosen. So if you look at this wound, do you think it's infected? Always hard to see, I know, from a slide, but this is a 58-year-old gentleman who's referred to the assessment unit for bilateral cellulitis. He said he'd had 3 courses of oral antibiotics and there's no improvement at all. However, when the nurses looked at him and did a proper assessment, they found he had no infection at all. His erythema was secondary to venous insufficiency, and had they done that right at the beginning, they would have realised he needed compression. So therefore he was misdiagnosed. This wasn't infected, but people saw the red legs there and thought straight away, this must be infected. But had they looked at the wound infection continuum, they would have been able to differentiate. Similarly, is this infected? This is a 73-year-old gentleman with a chronic ulcer to the dorsum of his foot. His wound exudate was increasing and he had oral flucloxacillin. Again, there was no wound infection at all and he needed compression therapy. These are often confused. And again, why we need to understand that wound infection continuum to be able to link it into our clinical practice. So to have effective wound management, prevention is key. If we can, we want to be able to prevent any wound becoming infected, but we need to understand the clinical signs and symptoms and refer to the wound infection continuum and our local guidance. We need to identify causative agents that may be causing infection and remember to cleanse the wound first so you can undertake an in-depth assessment and cleanse the wound prior to any wound swabbing. We should initiate appropriate antimicrobial interventions, so only if they are required, not for this just-in-case scenario. And we can consider non-antibiotic antimicrobial interventions, which link in really nicely with the antimicrobial stewardship agenda. So we can look at topical wound infection therapies and cleansing solutions. Also remember the 2-week challenge, which I mean by that, you start your therapy, keep it in place for 2 weeks. If there's no improvement or there's lots of deterioration, then consider re-evaluating again and changing that dressing regime. And remember, accurate assessment and clear documentation is clear. The next person to come to see that patient must understand and be able to follow your care plan and what you planned prior to that. So thank you all very much for listening. If you have any questions, please pop them in the chat box and I will be delighted to answer them for you. And hopefully you put them in the chat box throughout. And I'd like to hand over to Miriam now, who will explore and discuss the range of wound products and wound dressings that you may wish to use when looking at developing your care plans based on the wound infection continuum. Thank you so much for listening.
Thank you very much for your impressive presentation, Karen. Let us now look at how we can prevent wound infections, but also how to treat them when a patient already presents with signs of an infection. Karen already introduced the wound infection continuum. With our B Brown version, we additionally want to help you as healthcare professional to make the right choice when it comes to our products. So we all know that infections are caused by microbials, such as bacteria, which do not only like to multiply, but they also love to produce biofilm. Biofilm forms when bacteria adhere to surfaces and excrete a thick and slimy substance where the bacteria can perfectly grow a colony inside. Because the biofilm protects the bacteria like a shield, also against many antimicrobials, it presents a constant threat for wound infection. So, as Karen mentioned, it is important to apply anti-biofilm strategies, which includes doing a proper wound bed preparation. First, by cleansing the wound with our Prontosan wound irrigation solution. Because if you want to be vigilant, you need to be able to assess the wound, right? And at the same time, to effectively prevent an infection, also consider applying Prontosan wound gel, which additionally offers a long-lasting cleaning effect. If a patient already presents with signs of an infection, which you need to manage, consider an antimicrobial such as our ionic silver product Askina Calcitrol. So you might have noticed that there is no strict border between using Prontosan gel or Calcitrol, because to decide if you need an antimicrobial, you always want to include the intrinsic and extrinsic factors of the patient into your assessment, such as, for example, a weak immune system or the hygienic circumstances. If you're using an antimicrobial, you always need to re-evaluate after 2 weeks whether you can step down to the prevention strategy with Prontosan gel, or whether you need to give the silver treatment another 1 or 2 weeks to work. Depending on the wound condition and risk factors of the patient, systemic antibiotics may be additionally considered once the infection has manifested. But we do not want antibiotics to be necessary in the first place, right? So let's focus on prevention instead. Let's look at the 3 steps of wound bed preparation. First, cleanse. If you wonder why you should cleanse the wound with Prontosan irrigation solution instead of saline, just think about a simple comparison. You do not wash your hands without soap either, do you? In a minute, I will show you why this is key for the wounds as well. Second, debride the wound. If needed, for example, by sharp debridement, but even soft debridement can effectively remove slough and debris when you use our Prontosan debridement pad with microfiber technology. And last but not least, prevent wound infections with the long-lasting cleaning effect of Prontosan gel or Gel X, as it can remain on the wound bed until the next dressing change. So if you have deep cavity wounds or fistula, use Prontosan gel as it is more liquid than Prontosan Gel X, which in turn is perfect for the more superficial kinds of wounds, or by the way, also for burns. Please always remember to protect the wound edge when you use any kind of wound gel. For example, by applying Askina barrier film swabs, because otherwise the wound edge might become macerated. And as usual, you will choose the right secondary wound dressing depending on the level of exudate. So what makes Prontosan so unique for wound bed preparation? What did I mean by comparing it to washing your hands with soap? Here they are, the 2 superstars in Prontosan, betaine and polyhexanide. Betaine is a surfactant, so this is basically our soap here. Let's first have a look on how the surfactant works. And before, let's put this complicated molecule in an easier to understand graphic. A surfactant molecule basically consists of a hydrophilic water-attracting head and a water-repellent hydrophobic tail. Since the tail doesn't like water, it searches for another place to go, which here is our biofilm. The polar heads of the surfactant molecules have the same electric load and therefore they repel each other. This is how the biofilm breaks up, and so it can be much easier removed from the wound bed. But also, the beta-ene has opened the door now for the supportive effect of polyhexanide in Prontosan, which can now act on the bacteria. So let's look at what actually happens with the bacteria now as polyhexanide can break through and finally reach them. To do so, we need to have a deeper look at the microorganism and to be more specific on their outer layer. Because the outer layer of the cell is negatively charged and the polyhexanide molecule, on the other hand, has several positive charges, which causes it to act like a magnet, and so it attracts different parts of the outer layer. So the layer is disrupted and begins to leak. With the loss of this bacterial integrity, the cytoplasm escapes from the cell, and this causes the bacteria to die. To sum it up, beta-ene breaks up the biofilm and opens the door for the supporting effect of polyhexanide, which can then act on the bacteria. A lot of companies use in vitro tests to prove the antibiofilm efficacy of their products. Prontosan has recently been tested on various test methods, which were performed in 2 different laboratories. They compared Prontosan with 2 other wound irrigation solutions on their antibiofilm effectiveness against Staphylococcus aureus, Pseudomonas aeruginosa, and Candida albicans. The results show that the effectiveness of products on biofilm highly depends both on the test model and the microorganism. But what is important is that Prontosan was effective in all models and for all of the microorganisms tested. And it's therefore the solution with the most versatile potential in the fight against biofilm and chronic wounds. The efficacy of Prontosan has also been demonstrated over many years in a large number of clinical studies. But since we would be quickly running out of time here, feel free to reach out to us if you're interested in more clinical evidence. So we have now seen how to do an effective wound bed preparation with Prontosan solution and Prontosan wound gel to remove the biofilm and to prevent an infection to occur. Let's now look at what Askina Calgatrol does when a patient already presents with an infection. Silver may be incorporated into wound products as elemental silver, such as nanocrystalline silver, or in the ionic state. Askina Calgatrol contains ionic silver within a calcium and silver-containing alginate matrix, so it automatically comes with the absorbent characteristics of alginates, but also acts against a broad spectrum of microorganisms, including multi-drug-resistant bacteria. As opposed to several other silver dressings, there is no activation needed before application. It is active with immediate effect, but due to its sustained release of silver ion, the antimicrobial effectiveness lasts up to 7 days. After being removed in an atraumatic way, you will find no gray or black stains from Askina Calgatrol in the wound. Askina Calgatrol is available in 3 different formats, all containing the same ionic silver technology. Calgatrol as a paste, Askina Calgatrol thin, an ionic silver alginate matrix, and Askina Calgatrol AG, an absorbent polyurethane foam layer on top of that matrix. While Calgatrol paste is suitable for all kinds of wounds, the thin especially fits to flat superficial wounds with low exudate, deep cavities, or difficult to dress wounds. Calgatrol AG provides extended absorbent characteristics due to the additional foam layer. And how does Askina Calgatrol work? Askina Calcitrol delivers a controlled and sustained release of silver ions into the wound. How do these ions release? When Calcitrol gets in contact with wound exudate, the fluid is absorbed into the alginate matrix. The matrix swells, which causes the silver and calcium alginate molecule to release the silver ion into the wound. Since the alginate matrix contains bonded water in its structure, a wetting of the product before the application is not necessary. How do the antimicrobial effect of the silver ions work? The main antimicrobial mechanism of silver ions is the structural damage of the bacteria cell wall. This mechanical action is accompanied by some supplementary effects, since silver ions can also interfere with the DNA and RNA of bacteria and thereby disrupt protein production and cell division. If you want to know more about the Askina Calcitrol range, Wounds International has recently published this Made Easy document, which offers you valuable insights into the mode of action and the different applications and much more. They also published new evidence for Calcitrol in the management of non-malignant wounds with signs of infections in oncology patients. The treatment of 15 cases was considered as effective, well tolerable, and safe for these especially high-risk patients, and it resulted in significant improvement of the wound. Odor and pain were reduced, and at the same time, quality of life of the patients improved. While healthcare professionals assessed Calcitrol as easy to apply and remove, the treatment duration was between 2 and 4 weeks. Again, showing that silver must be used under careful re-evaluation after 2 weeks. I hope this presentation has shed some more light on how to prevent a wound infection and to enable a proper wound assessment. But if a patient presents with a wound infection, consider ionic silver to get that infection under control, and then step down to a prevention strategy with Prontosan gel. Wound cleansing should obviously be done with Prontosan solution in all stages of the wound infection continuum to effectively remove slough, debris, and biofilm. Miguel's nurse, Fernanda Cortes, will now elaborate on the patient case and the combination of products she used to prevent and manage a wound infection.
Hello, my name is Fernanda Cortes and I'm Miguel Hiopia's nurse. In the following, I will outline his clinical history. The patient is 60 years old with no comorbidities. The patient was admitted to hospital on March 19, 2021, diagnosed with pneumonia due to COVID. He remained in the intensive care unit for 39 days. When he was discharged on April 26, he had developed a grade 3 pressure ulcer. I was then providing him with one-to-one care at his home. To access his wound, I used an integral rating scale known as timers. Accordingly, I have focused on these 4 pillars: cleaning and wound decontamination, management of the bacterial load, reduction of the bacterial load, and management of the exudate as well as the peri-wound area and the wound edges. At my first visit, Don Miguel's pressure ulcer had a size of approximately 10 by 12 centimeters. The depth could not be estimated correctly at this stage because of the devitalized tissue that was present. In addition came a critical colonization or an obvious local infection, increased exudate and intense pain, which was causing the patient incredible discomfort. In Latin America, the concept critical colonization is still used to refer to a wound in which the patient does not have a local infection yet, but shows signs of an inflammatory phase which is difficult to manage. With hypergranulation and constant pain and bleeding that can be very easily induced, and an unpleasant smell. As we know, the 2016 consensus removed the term critical colonization from the wound infection continuum. Even though the covered signs of a local infection are the same, I think this critical colonization concept is ideal to differentiate between an inflamed wound with delayed healing due to a high bacterial load that may be present in a pressure ulcer and a properly infected wound. The picture we are looking at shows the condition of the wound on April 29th when I performed the first of 39 treatments. I started the management by cleaning and decontaminating the wound with Prontosan solution to lower the bacterial load. After that, I started with the management of devitalized tissue. Initially, I used hydrogels and traditional dressings, since we did not count on the support of B. Brown and its advanced wound dressings yet. As it was obviously a wound bed with critical colonization and a large area of devitalized tissue, I continued to manage it by reducing the bacterial load with Prontosan solution and Prontosan gel. The gel remained on the wound between one treatment and the next, on the area of devitalized tissue for autolytic debridement. In addition, whenever possible, mechanical debridement was performed during the treatments. I covered the wound with Askina foam dressings once I had them available. On this image, we see the 8th of 39 dressing changes. Signs of tissue with hypergranulation is visible. Every contact with tweezers or some light dressing caused bleeding at this stage, with unpleasant smell and a huge amount of exudate. Therefore, I continued the management with Prontosan gel in the area with devitalized tissue, and additionally, I used Askina calcitriol foam with silver ions. Together with Prontosan solution, this has helped to reduce the hypergranulation, the bacterial load, and the critical colonization of the wound. This picture shows the situation of the 12th dressing change. The wound edges are a little less macerated, due to the efficient management of exudate with the foam and the skin barrier products we used. I also continued the use of Prontosan solution and mechanical debridement whenever it was appropriate. Well, the dressing change number 14 shows that the hypergranulation has much decreased. Therefore, I stopped to use ionic silver. And in dressing changes 20 and 24, I further managed the wound with mechanical debridement of the devitalized tissue, as can be seen. Prontosan gel was constantly applied to the cavity, and we can recognize a major reduction of the wound size. However, the depth of the cavity was the most complex challenge throughout the wound healing process. It has cost me a bit more to decrease the dimension of the depth. So I continued, as I was saying, treating the cavity area with Prontosan gel. Additionally, I used Askina foam dressings to manage exudate and wound moisture. Well, this is a picture of dressing change number 25. We see a wound of which the dimensions are already much smaller at a depth of 2 centimeters. As I mentioned earlier, that was the most difficult process during this healing procedure, to be able to reverse those dimensions. However, the dimensions in terms of the wound size decreased significantly. I continued cleansing with Prontozan to reduce bacterial load. I used Prontozan gel together with Askina's silicone foam dressings to protect against moisture and exudate. In this picture, we can see that the wound has become much smaller with a significantly reduced cavity, however, at the same time, difficult to handle. But it was a great relief and even joy for us because the wound has already become much smaller. I now started to protect this perilesional skin, which can be seen where it was already healed, with Linovera. And in this last picture, you can see the closed wound, to which I continue to apply Linovera. Well, here I am with Don Miguel when I treated him for the last time. After all these months of treatment, which lasted 4 months, if I'm not mistaken, Don Miguel is finally able to live a normal life again. Well, that was the story of the case of Miguel Chiopia. Thank you very much for your attention and see you soon.
Muchas gracias, Fernanda. Thank you very much, not only for presenting us with the patient case, but also for the good wound care that you have provided to Miguel. And I think we just let him speak for himself now, so that he can tell us how he feels now after the wound has healed and after he gained back quality of life.
Hello. Today I want to share with you the joy of my recovery from my pressure injury that took a really long time. 4 months of healing, 40 treatments, and thanks to the professionalism of Nurse Fernanda Cortez, I was able to make progress and resume my normal life. Now I'm glad, I'm happy. It was very good to return to work. I had a great welcome from my colleagues and my co-workers. With the help of my family, I was able to take my life back. Talking about family, as a father and as a husband, being able to do the simple things, like sitting down at the dining table, or being able to take a shower, things that seem simple for most people but are real meaningful, if you lost the ability to do such things for 4 months. Then simply being able to take a shower and sit at the table bring you joy. And I want to share this joy. Even though it required care and sacrifice, I am now happy and would like to share that joy with all of you. Hopefully, this will never happen to me again or to any other people. Nobody should go through what I went through. A warm hug to everyone. And I want to share the joy of being alive in this new stage of my life with more energy and more vitality. Warm greetings to all.